So for each of our speakers, asking them to go through an entire round summary of treatment is quite a task, and you did a wonderful job of getting us through that. And I will remind folks that the slides will be posted to the website so you can kind of go back and digest, so to speak, without a gastric sleeve, what was seen. So next we're going to talk about what works in the treatment of children. We have one of our roundtable members, Dr. Ihuoma Eneli, who will be speaking to this. Dr. Eneli is a member of the American Academy of Pediatrics Institute of Healthy Childhood Weight. In fact, she's the associate director. She's board-certified general pediatrician, professor of clinical pediatrics at The Ohio State University College of Medicine, and is the medical director for a comprehensive pediatric obesity treatment center there. She has particular interest in intervention research in pediatric obesity, serves in a number of regional and state capacities. She did get her medical degree from the University of Nigeria, and then her pediatric residency at Michigan State University. She also received a Master's of Science in Epidemiology and completed an NIH clinical research fellowship at Michigan State University. So, Dr. Eneli, thank you.
Well, thank you, Don. Good morning. So I will do exactly what Sue did for the pediatric population, slightly differently. There were three parameters that guided how I put together these slides. So the first is that I focused on studies that were meta-analysis or systematic reviews. The second is that I had to figure out what does effective treatment mean for the pediatric population. It's a little clearer in adults, but not in pediatrics. And so I chose an effective benchmark that would speak to most of the stakeholders in this field, as well as a benchmark that's objective and measurable. And then the last one, which I think is the most important, is that a child is not a small adult. And when we go through our slides, I want us to keep that in mind, because there are multiple things that we have to consider when we look at effectiveness. Use that one? This one. Okay. So, according to the US Census, there are 18.5 million children who are overweight, have obesity, or severe obesity, because 1 in every 4th child has one of these conditions. And when we look at treatment, what's happening to them? If I extrapolate it from the study at the bottom of the slide, about 1,200 get weight loss surgery a year. That means that we still have 18.5 million children who get lifestyle intervention, medical treatment, like medications, and then a large proportion of them get no treatment at all. Why is that important? What do we know about these kids? We know that they are at risk for multiple comorbidities that are serious, and that it affects all organ systems. We also know that when you have obesity as a child, there's an increased likelihood that you will have obesity as an adult. So in 2007, the AHA expert committee provided recommendations on treatment. And what they did was to grade the treatment into 4 stages. In the first stage and the second stage, the treatment happens in the primary care office. So the pediatrician or the nurse practitioner delivers it. In stage 2, there's an allied healthcare provider that's included. When you look at stage 3 and 4, we're talking about a multidisciplinary team that provides frequent and more intensive lifestyle behavior modification. And by the time we get to stage 4, we're looking at bariatric surgery, medications, very low-calorie diets. So from stage 1 to 3, the predominant treatment is lifestyle modification. For stage 3 and 4, that's where we see the kids with severe obesity. And there'll be a panel later on severe obesity. And so I am going to just touch very briefly on that topic. So when we learn what works, there are 4 buckets, right? We look at the different categories of obesity in children. And I've added one called crossing weight percentiles, because typically by the time a child has obesity, they've crossed percentiles very rapidly. We also will look at the types of treatments, the settings, and the stakeholders. I will focus on these 2 buckets. So, in November 2016, the US Prevention Services Task Force published their recommendations. This was an update from the 2010 recommendation. And what they found was that for children 6 years and older, that clinicians screen them for obesity, and they offer them or refer them to comprehensive, intensive behavioral treatment to promote improvement in weight status. It was given a grade B. And a grade B means that there's moderate certainty that there is substantial or moderate net benefit of the intervention. So the screening test recommended is the body mass index. There were no recommended intervals. And when they looked at harm versus benefits for these lifestyle modifications, the harm of screening was minimal, and there was modest benefit. Well, what is our measure of effective treatment? Or what measure did I pick? We want to use a standardized measure. So we're going to use the BMI Z-score, because it allows us to compare children of different ages and interventions in different settings. Some studies have shown or suggested that a reduction of 0.15 to 0.25 in the BMI Z-score is associated with improved cardiometabolic outcomes. If we keep that in mind, another study also showed that if you reduce the BMI Z-score by 0.2, it approximates roughly a decrease of 5% of your body weight, which is a benchmark that the adult population use. So for the rest of my presentation, I will be using a decrease of 0.2 BMI Z-score as our measure of effectiveness. Because I used a lot of meta-analysis, I'm going to show forest plots. Most of us are familiar with it, but the way to look at it is that you have a group of studies that met the inclusion criteria based on quality, and they're all listed here on my right. And what we want to look at is the thick line in the middle that has a 0 at the bottom. There's a diamond that corresponds with each study, and every diamond that is on the right of the thick line favors the treatment. The big diamond is our pooled effect of the treatment over the control. So in this meta-analysis, what they did was that they grouped it by contact hours, so 0 to 5, 6 to 25, 26 to 51, and more than 52 hours. And most of these contact hours occurred over a 12-month period. Their treatment duration for most of these studies was 6 to 12 months. Since we're interested in what is effective, let's see if that comes up here. We'll look at the top 2 buckets. And what it shows is that if you have a lifestyle behavioral treatment for children, and they have more than 52 contact hours over that time period, you will see an effective change in their BMI-Z score. You will also see an effective change, though lower, if it's between 26 and 51 hours. Well, what's in the treatment? What do these treatments look like? Again, I'm going to emphasize the two groups that were effective. That didn't quite come up. So some of the treatments had group sessions, others had individual sessions, some had both. They had parent only, child only, both. There were frequently referral programs. And that's important. They weren't necessarily primary care-based programs. There were referral programs to specialty clinics, and they had the 4 key components: nutrition, physical activity, behavior modification, things like goal setting, stimulus control, and problem solving. Let's look at the children that are younger than 6. Now, this is a Cochrane review that also shows, looking at our forest plot, this was done more with time of the intervention and follow-up. And we see that these lifestyle interventions actually all fall to the right of the line. So they are effective in reducing the weight. And looking at our changes in our BMI-Z score, we see changes as much as 0.38, 12 to 18 months from the baseline of the intervention. Now, we're not surprised about that because we factored in growth, and these children are growing. What does it mean? So if there are parents in the room, they're probably figuring out, well, what's a 0.2 decrease in BMI-Z score? This is really what it means. If we look at a growth chart, and I have a child, an 8-year-old, at a height of the 50th percentile, at the 95th percentile, which means that they have obesity, and I take them down right below the 85th percentile, which means they become normal weight, that is a decline of 0.6 in BMI-Z score. That child, at that time, needs to drop 8.6 pounds to get to that point. So if we look at our 0.2, and that's all we need to do to get some outcome, a cardiometabolic outcome, then I'm asking that 8-year-old to drop 3.3 pounds. Doable. Now, if I factor in 12 months, that child can actually gain 6 pounds over 12 months because they'll grow about 2.5 inches and still have that benefit of a decrease in 0.2 in their BMI-Z score. Now let's look at a 16-year-old that's almost done with her growth. What does it look like? Not very bad either. Again, obesity to overweight. We want her to drop 25 pounds. If we look at a decrease of 0.2, it drops down to 9 pounds. And if I give her 12 months, we're talking about 5 pounds. What about cardiometabolic and psychosocial outcomes? In children, we talk a lot about the psychosocial effects. What do the studies show? The 2016 US Prevention Task Force meta-analysis had mixed results. There were some improvements with this decrease on blood pressure, not so much on lipid panel, a little bit on your glucose metabolism. However, an earlier meta-analysis by Mandy and Ho in Australia did show that if you decrease the BMI-Z score by 0.2 or 0.3, they found that it affected both your lipid panel, your fasting blood sugar, your blood pressure. So it showed that there were positive outcomes on those variables. And then all the studies in with bariatric surgery show a clear benefit on your cardiometabolic outcomes. For our psychosocial outcomes, Interestingly, there were no consistent difference in quality of life, self-esteem, or depression for the studies that reported it between the intervention group and the control group. On the positive side, there was not an increase in disordered eating or eating behavior in the children that received the treatment in comparison to the control group. Let's slow that the wrong one. So when we talk about learning what works, does the intervention dose matter? Yes. We really think, or the evidence shows, that at least 26 hours at minimum, and even better, 52 hours. If you look at that over 6 months, that's 2 hours a week for that child and family. Does the sample ethnicity matter? Yes, it does. But the evidence seems to suggest that these interventions are equally as effective whether you're Latino, African American, or non-Hispanic white. A large number of the studies targeted Latino population, and 2 of the very large studies that had 52 hours or more had close to 60% of their population were African American or Hispanic. Does the intervention length matter? Yes. 12 weeks, which a lot of places offer, is not adequate. Most of the studies looked at 6 months as your minimum. Does the structure matter? The parent only versus the parent and child matter. Does it matter? No. The data in that area, the evidence in that area is inconsistent. And does the effectiveness measure matter? I would say yes. So every time I go down that rabbit hole of looking at the weight, I have a parent that sits across from me and tells me how happy she is with her child because he has better self-esteem and he does chores at home. So I think for pediatrics, we have to pay attention to, while I've selected BMI Z-score, we have to find a way to objectively measure and incorporate some of these psychosocial outcomes in a meaningful way. So now let's look at setting. This is primary care. The evidence is mixed. A meta-analysis by Mitchell et al. In Health Psychology last year found there was a small effect size in terms of improving their weight status. And it was larger if, again, you had more treatment contact. And interestingly, if that treatment contact happened with the pediatrician included. However, a more recent meta-analysis by SIM found marginal effect. And the way they describe this marginal effect is that if you compared a 10-year-old in the control group with a 10-year-old in the intervention group, what you would find over 3 years is a 1 kilogram difference between these two kids if they had an intervention in the primary care setting. The community-based intervention, we always talk about school-based interventions. Right now, there's no evidence to show that it does decrease the BMI Z-score. It can be an adjunct treatment, but just solely on its own, there's no evidence. I talk about the MIND program, which is very popular. The YMCA will be adapting this program to their community settings, and it did have more than 52 hours and showed a decrease of 0.2 in BMI Z-score at 6 months that carried through by 12 months. So for medication, these are all the medications. We're always jealous of our adult colleagues because in pediatrics, we might as well remove the bottom 7 and just look at 2. And that's these 2 medications. We have some trials out, published trials. And again, we see a small effect, not as good as lifestyle intervention. Let's talk about specialized diets. We've started looking at specialized diets for kids who have severe obesity. So our high protein, low carbohydrate diet may offer an option. And you can see at 12 weeks that the low carbohydrate diet decreased the BMI Z-score by 0.25. We've also looked at something called a protein-sparing modified fast. The protein-sparing modified fast is a very low carbohydrate diet of 20 to 40 grams of carbohydrate a day, and you're really trying to push that child into ketosis. And it's used for specific conditions. So the child that I'm showing you is a 16-year-old with a BMI of 99 who was put on this diet and decreased his BMI to 85 and finally made it to surgery. So there are opportunities to look at some of these treatment options. Talked about weight loss surgery. I have exactly 2 slides on it since you'll be hearing much more about it later on. The gastric sleeve is now the most common surgery that is performed, even in the pediatric population. And when you look at the Teen Lab study, and the Teen Lab study is the contemporary of the study and that was earlier presented, but for adolescents, what you see is that at baseline, 97% of these kids had a BMI at 40 or higher. And at 3 years, only 37 of them had that BMI at 40 or higher. We know that the median decrease with bariatric surgery is 30%. And that brings up, at what age do we do it? So learning again what works. Does intervention dose matter? Yes. Does the implementation setting matter? Yes. Does the age matter? Yes. Does the intervention type matter? Absolutely. And does the intervention length of follow-up matter? So most of the studies that are presented, the follow-up was a year or 24 months. We need much longer follow-up studies. There's one follow-up study that was by Len Epstein that showed that about 42% of these kids, or 48% of them, 10 years out, were actually no longer had obesity. So there is possibilities. We just need more studies on them. What are our opportunities? I'm going to fly through the last 3 slides. Are we using the right effectiveness measure? Should we look at a deck of effectiveness measure rather than one? And should we pay attention to how relevant it is to the stakeholders in the field? Are we training the right people? And how do we support care in each of these delivery systems? How are we able to provide this care in the clinical setting, in a community setting? But more importantly, is there a mismatch between the intervention and our outcomes? So I'm not showing the change, but if you take a 52-hour contact hour intervention and apply it to a child at the 90th percentile, for very little weight loss, even for the 16-year-olds, about 3.5 pounds, that child will become normal weight. So the question is, yes, we're applying this, but we're doing it for children with severe obesity, BMIs above the 95th, above the 99th. Should we reconsider who we use these interventions for? And should we pay attention to when the cross percentiles? Does that make sense as an effectiveness benchmark for pediatrics? We also have to talk about integrating these programs. So what you're seeing up there is what we're doing in Columbus, Ohio, where as a tertiary care program, we're training primary care practices, and we're also working with community organizations and trying to bring everybody together on the same, in the same room, so that what we have is a personalized, redundant messaging that has probably a better chance of being effective. There are also studies looking at how you integrate these settings that was recently funded by the CDC, so the Childhood Obesity Research Demonstration Projects, and their results will be coming out soon. And finally, there are other opportunities like provider training. Again, we talked about defining our benchmarks. What about our research funding? Research funding that goes beyond 2 years would be nice. Integrating technology. Again, allowing us to give even more redundancy to the message or the intervention, and improving our efficiencies and our effectiveness. And finally, linking outcomes to policy on reimbursement and population health. Somebody has to pay for it. And we have to find a consistent, systematic way in which it is paid for, because our children deserve it. Thank you.